acceptable just to click the continue button?
No, actually, I've been advised that as a backup, it's good to verbally ask the question.
Okay.
So I always do what my lawyers tell me.
Oh,
That was not
I'm
my
so
advice.
sorry about that.
And that was not my advice.
No,
As I said to someone last night, it's often a much better idea to frame your question to the lawyer of how best can I accomplish this, rather than can I do this?
oh no, I've learned that that's the wrong question.
Yes.
Can I do this? Is
Because
just
the answer is always no.
it's an engraved invitation.
Yes.
See, I always think the answer is always going to be, it depends, which is even more frustrating.
I was on a condo annual meeting last night, and my building still has all these COVID restrictions in place. You know, only one person or one family in the elevator at a time, and you know, wear your masks if you're out in the hallway or whatever. I'm in an affluent building in Riverdale, New York City, where I would swear probably 95% of the people and all of the staff in the building have been vaccinated already, because everybody I've talked to has already been vaccinated. And, you know, they said, well, we don't know who's been vaccinated. I said, well, why don't you do a survey, an anonymous survey of all the residents? They can choose to share their name or not, and just find out, you know, see if we know it's 80%, 90%. Oh, some other buildings in the neighborhood have asked their lawyers about that and been advised not to do it. Like, okay, maybe you need to go back to your lawyer and say, how best can we get this accomplished?
Yeah.
That's almost funny.
Yes. Or you just don't ask them. That's what I do.
Well, yeah. I mean, why did you go ask the lawyers?
I apologize later.
Survey to get data. I mean, really.
What's the cliche? Better to apologize later than to ask permission now?
Yes, exactly.
Out of order. All right.
Better to ask for forgiveness than permission. That's
yes.
it.
Yeah, that's it.
That's
Thank
it.
you.
That's it.
That's it. Thank you.
I think I have a
All right,
needle
so
point.
fire away. I'm on the hot seat here.
All right. So this is, Kathy, this is the first of these interviews that we're doing.
Oh boy, I like being a guinea pig.
Well, honestly, we that was deliberate because we thought you would be the right start, because you really have a lot going on, and you know, you're doing a lot of what we talk about, right? And
Yep.
so hopefully we get some framing out of this, some insights out of this that are helpful subsequently, because people are doing less than you are. Anyway, that's the scoop. Amanda, you're taking notes, correct? I'll also take some, but I just want to be sure. We can, so we don't have a format in particular for this. So what I'm thinking, and you know, we're all friends here, is that I will start off with the questions that we already showed you during the meeting and that you've seen. And then we have subject matter experts here who should chime in any time and take over from me, because I know the least of anybody here.
All right, then I'll ask a question now.
Go for it.
Which is, Kathy, I've certainly been on some of the same phone calls as you, and I thought you were great on that ONC call this week, by the way. That was really informative. Could you, and not just because you plugged the project, but, and Adam, this would be a suggestion for any of the phone calls, is that in case there's someone on the call who isn't aware of like what your basic program is, if you could like hum a few bars at first, just to give the overview of it, because that'll help me put in context the questions I might want to ask.
Absolutely. And I think that's an important thing to do, because you've seen one of us. And there are some general principles that are certainly generalizable, but the circumstances, I mean, I just got off an ONC call with it for the STAR HIE program that is essentially all HIEs, and, you know, or all the awardees are HIEs. There are, I think, 20 some odd of us. And, you know, it was on information blocking, and everybody was agreeing that, you know, general questions have to be answered in the specific, because every state is a little bit different.
Right.
So I'm the Chief Operating Officer of the Bronx Rio, which is one of 6 state certified HIEs in New York State. We've been around for 15 years. And we operate on a membership model as a not-for-profit. We were formed by the healthcare organizations in the Bronx and now beyond the Bronx. And our board is composed of representatives from 10 health organizations, hospitals, FQHCs, nursing homes, visiting nurse, the New York City Health Department, and we also have a consumer representative from the Borough President's Office. And New York State's HIEs all operate on, or our state law is that we must get affirmative opt-in consent to provide access to data by anyone at any of our member organizations. And the way that New York State is set up, once an organization joins a RIO, so we have a board approval process, so take Montefiore Medical Center, they join, they sign their agreement with us, their BAA, their participation agreement. They can send any data they want to send to us without patient consent. And that includes Part 2 data, behavioral health data, anything. Because with the statewide opt-in requirement, no one can access that data without us having a patient consent on record for that facility. And this model is about to change, but I'll tell you what it's like today, and then I'll tell you where they're going to go. So right now, patient consent is facility specific or organization specific. So at Montefiore Medical Center, for example, which has 4 hospitals and many hundreds of affiliated physician practice sites, et cetera, there's one agreement with the overall health system. And if patient can sign a consent at any of their locations, that's good across the entire organization. And that consent includes language about the data that a provider organization can access through this consent may include any of your confidential data or sensitive data, including your substance use, behavioral health, HIV, other what are called minor consented services in New York State for reproductive health and STDs and adolescents accessing behavioral health and stuff.
Kathy, can you send us that at some point so we see the exact language? Thank you.
Mm-hmm. It's on our website, Chris, but I will send it. So every organization, I mean, the way this is operationalized is each organization, as we bring them on board to provide data to us, which is done in HL7 V2 or CCD feeds, an occasional flat file. They put a field into their EMR that basically has 3 to 4 potential values. Unknown consent is the default. Yes, if the patient signs the form, yes, and no, if the patient signs the form, no. And in hospitals, we also have a value for emergency only, where the patient is saying, only in an emergency situation can somebody access my data. And that we actually credential users in ERs, ICUs, and labor and delivery to be the only ones who even could possibly break the glass for those. There are certain types of limited messages and data we can send without consent. So for example, hospitalization alerts, ED, admission and discharge alerts, which just include the fact that it happened, the patient's name and MRN, and a diagnosis if there is one in the message. Those can be sent based on treatment relationship or plan enrollment. Everything else, access through our portal, requires that the patient be consented. If the patient hasn't consented at your facility and you try to look the person up, you get a message saying no data is available. It doesn't tell you whether they said no or whether they're still unknown. It just stops you. We also do a lot of reporting, and the reports are often filtered based on consent. I mean, if they're just a digest of the alerts and we're putting them in a report instead of an individual message, we'll do those without consent. We do have what we call a quality improvement consent, which is based on the language in that consent form that says that one of the allowable uses of the data that's in the Bronx Rio is for quality improvement activities. And so our lawyers have ruled on that one that as long as a person has signed a consent somewhere in the Rio and is known, has a treatment relationship or plan enrollment with the organization doing the quality improvement project, that we can provide them with data on that person, even if the person didn't sign a consent at their organization.
Is that, I'm sorry.
I was just gonna say that makes sense to me if it falls under the HIPAA exception around population health studies, analysis, right?
Yep.
Yeah.
Yeah.
Okay.
And
Is that documented somewhere, you know, the lawyer's judgment?
That's common knowledge, I would say, in the consent world.
yeah,
Okay.
we have, it's in our policies and procedures. That we can do this and what the process is. The QI project has to go through our research and QI committee and get formally approved as part through our board committee approval process. And we track the projects and we log everything so that, because we have a requirement as a New York State certified HIE that if a patient comes to us and says, I want to know who's accessed my data, we have to be able to tell them everybody that we've released their data to. So we log everything that goes into the reports as well as all of the portal accesses.
I think that's a HIPAA requirement too.
Yeah,
Sorry.
probably
Yes.
trickles down from HIPAA.
Kathy, I have a question. Something you said before. You said when they go into an emergency room, I think there's an alert and that does not need a consent.
Yep.
So who does the alert go to?
We have members who subscribe to alerts on groups of patients. So they may say, these are my managed care risk population. They identify that cohort for us, and we set a flag to say, yes, they want to get an alert on this.
Okay.
We are, if you're aware of the latest federal requirement that hospitals have to send event notifications to PCPs and others designated by patients, we are doing that for our hospital systems.
Okay.
They owe you big.
Yeah. Well, they also appreciate it big because on their outpatient sides, they now don't wind up with multiple alerts about those events on their entire primary care population. Because we weed out if it's within the organization or if we've already got a subscription on them, or, you know, we make sure that only one alert goes out on them.
There's also a movement in many states for those events to be reported to the Medicaid agency or to the agency that's running the waivers, which is outside of the non-medical, especially because of the GAO report of fraud and other issues.
Yeah, that's not been a request in New York.
Okay.
Medicaid is, I'm sure they're doing prior approval of where they need to, but, and they, they know about the events because there's electronic insurance verification going on. So whenever anybody gets registered with a Medicaid card, it gets checked in the EMEVS system, which is part of Medicaid's whole database. So they know if there's been an EMEVS inquiry on a patient and where it came from. So we haven't been asked to do that.
Okay.
So one of the things that we've been doing for many years is, in addition, and this is not true of some of the other New York State RIOs, we have included community-based organizations in our membership for at least 10 years. And the way that we handle the fact that they're non-covered entities is that in our participation agreement, there's a requirement that any participant who is not a covered entity must comply with HIPAA regulations, must, act in accordance with them as if they were a covered entity, that their use of the data and their protection of the data is subject to audit by us, that they have to document for us that their staff take annual HIPAA training. And since the patient whose data they're getting access to is their client and the patient is consenting for that organization to get access to their healthcare data. It's an informed consent by the patient who is, entering a shelter or a supportive housing program or a food program, whatever it is, that yes, my health data may get access by these folks.
So I have a question about that.
Yep.
Did you all consider, first of all, I think that's interesting. And my first question is, did the community-based organizations, did you get them all to agree to that? And do you think they've actually complied and that they're doing the training and like they took it seriously?
Mm-hmm.
Great.
Yeah.
Is there a way, did you monitor that?
They've come to us and said, can you recommend which HIPAA training program you would think is good? We're about to implement a new learning management system because we're now required, as of a year or so ago, all of our authorized users have to undergo annual retraining on use of the RIO. And so we're now setting up we're getting a new learning management system and setting it up that will include access to a HIPAA training module for folks that might need it. And it will automatically document that all this training has happened.
So my other question then is, and I actually think depending on how broad your community-based organizations are, I can see how this might not work, but how under HIPAA, anyone who is involved in the care team of the patient, right? That is actually covered under HIPAA, under a treatment, technically, the treatment, prong that says you don't have to have written patient consent. So did you consider that option, and was that too bulky or too uncontrollable, or?
Well, in order for us to get an organization's data, they have to become a participant and join the RIO. So we're going to get their data anyway through that route. And since New York mandates the opt-in consent, it basically it's only come up as an issue in some of our other, we never considered it an issue. We've said, okay, we're covered with the agreements that we have and the consent. Because New York State goes farther than HIPAA by requiring the opt-in consent. So if something's okay under HIPAA, that's fine, but in New York State, it's not fine. We still have to have the consent.
And the opt-in consent that I'm sorry.
No, go ahead.
The opt-in consent that you're talking about is, what's the extent of what they're consenting to? Because I understand the concept that New York asked for more than what HIPAA does, but what exactly are they consenting to?
They're consenting to allowing authorized users at the organization where they are signing the consent to have access to any of their data that is in the RIO. And we, I'll send you the consent form, but basically we list out all of the various protected types of data. The language in the consent form is compliant with Part 2 requirements, and our tracking and logging is compliant with Part 2 requirements. We've got notifications set up that if Part 2 data is accessed, we do what we need to do. And so that can basically, at any participating organization, they're required to have a process in place to identify the people they want us to credential as authorized users. And so they have to identify 1 or 2 key people in the organization who have the authority to approve those users getting access to our system. And we have a process then, they send us all the information and we put them in the appropriate user role in our system.
So
So that
I have a
governs-
question, if a clarification, and sorry if this is naive, but so they sign, someone signs and it allows the authorized users of the organization which they're signing to provide access to Rio participants, right? Rio members.
to
Is
any data that is in the Rio. So the data that we have is from our participants. But when somebody signs a consent, they're saying, okay, I'm consenting to have Montefiore doctors access my data through the Rio, and that data can include data from any other organization where I'm treated, where the data is going to the Rio.
So what I wonder is there a way to, can they segment it? They can have some of my information?
They
can have all
cannot,
of it?
no.
Okay.
No, there's no option at this point for a patient to say, you can only have this type of data. There is an option when we do, which we haven't done much of because it's a bear to implement, but we have the ability to do multi-participant consent forms where there might be 15 organizations that are all part of the same IPA that they want to have on one consent form. So they could get consent for the IPA staff and each of the practices. By current New York State policy, the patient can sign that, but they also have to have the opportunity to say, I don't want this organization to get the data. So yes to 14, no to number 15.
what's IPA?
Independent Practice Association. It's a group of docs that come together largely for managed care contracting purposes. But they can provide, practice management services and all that kind of stuff. So they need access to the site's data.
I have a clarifying question based on Adam's clarifying question, which
Okay.
is, you said that when they sign the consent, they're saying that, you, Montefiore, if that's who you're visiting, have access to any information about me in the system. Does that consent also say that, and anybody else who is on that system, any other provider on that system or community-based organization also has access to it?
No,
Okay.
because the consent that they're signing, and I will bracket this with saying today, that essentially only says the consent they're signing only allows that organization staff to get
Okay.
access based on that consent.
So if
So
they
if they
have
sign a consent at Montefiore, it's not good at Urban Health Plan today, because Urban Health Plan is a separate.
Now, when you're saying today, is that because it's about to change?
Yes.
Okay, that's what we want to hear.
And is it, so if they go to, like, using your prior example, the housing shelter, right? They have to get the consent signed at the housing shelter also?
Yeah,
To get it, to allow the housing shelter to get access to the info.
exactly.
So have you considered, have you tried to have some kind of a universal, did you explore the idea of like a universal consent that lists all of the members on it so that people could do a blanket in one statement, let everybody have access to it? Or is it
There is one Rio upstate that does that. And they have a bevy of people who are sitting there manually putting information in or scanning forms, or because administering that, when that was at least first set up 8 or 10 years ago, was a bear. However, New York State, SHINY, the State Health Information for New York Network for New York, which is the coordinating body across all 6 of us New York State Rios, and which is sort of led by the State Department of Health and facilitated by a nonprofit that's contracted with the state called the New York eHealth Collaborative, or NIC. The policy committee that oversees this has been looking for ways, because historically there have been lots of folks that, you know, grumbled about, oh, I got to collect consent. This is a pain in the neck. But we've ascended, you know, why can't you be opt out like such and such a state? And the answer is you can't get access to Part 2 data if you're completely opt out. So if you're going to have to ask for consent anyway, if you want to be able to see behavioral health or Part 2 data, because in New York, certain behavioral health data is restricted to only going to other behavioral health providers. So if you're a primary care provider and you want to see your patient's mental health records, you have to get consent. So if you're going to collect it anyway, and you want to be non-discriminatory about how you collect it and on whom you collect it, because you can't just ask me for consent because I told you I was going to the psychiatrist, or you see that I'm on a depression med and you don't ask the next guy, you got to collect it on anybody everywhere anyway. So, however, the opt-in requirement puts us at a disadvantage in cooperating with and exchanging data out of state, because we're confined by having a patient consent on record to send it anywhere. And, you know, e-health exchange sites are not collecting a consent that's valid in New York. So they've accused the New York QEs of data blocking, because the New York QEs are saying, I can't send it to you because you're not giving me a consent. My law won't allow me to. And they still filed an information blocking complaint. It's really pretty ridiculous. But so in order to try to go to something that would be easier, perhaps, for the patient, although less privacy sensitive, and that would conceivably allow us to send data out of state. After a very long, audacious inquiry consulting engagement, they've come up with what they're calling an all-in consent, which would basically be a consent to access for all of my data, any type of data that's available in the Shiny, which means statewide, not just in the Bronx Rio, that would be available to any current or future provider or health plan with whom I have or create a relationship. And the form, I'm assuming they're going to change that state regulation or the policy that I referenced earlier in terms of multi-participant options, because it doesn't give you any opportunity to say anybody that you don't want to allow access to. It basically is all or nothing. You either say yes or you don't sign the form. There's not even a box on their suggested consent form to say no. It's just one box that says yes. And the plan is at this point, which we are all quite skeptical about in our little New York HIE community, because they want to get this signed on as many people in the state as possible, as soon as possible, once we figure out how we're going to administer this. And we have no technical infrastructure in place now to pass consent around across all of the 6 of us. But the consultants think that because 10 health plans touch 80% of the New York State population, that they should get the health plans to collect the consent. Now, most of the health plans who are participants in the Rios now don't collect consent, and they consider it a barrier. And so it's going to be really interesting to see how this thing rolls out.
When is this supposed to happen?
Our kickoff meeting is tomorrow, and it's supposed to happen over the next year. And it is, we're all, you know, feeling like mushrooms because the consultants came up with all of this, you know, and we kept telling them the issues that we thought would come up here. there is a statewide master patient index now that's managed by NIC, but not very well, where we all send our own master patient indexes, and we do have cross QE communication. So if somebody gets hospitalized in Manhattan, the Rio that covers them shares that alert with me because they know that I also know that person. And then if I have somebody subscribe to them, I can send that alert.
Okay, Kathy, I'm going to interrupt you for a moment because we're going to run out of time. So I want to ask you a couple of things, and then let you have the mic back. First, just to dot the I. I mean, all of this is paper-based and done by hand.
No, most of it is electronic.
All of this is electronic.
Yes.
And
so
great.
When a person shows up at a hospital or a clinic, they are asked to sign a Rio consent. And at this point in time, most of that is done electronically because they've got the form in their EMR and they've got a signature pad. A few places still collect it manually and scan it. But then the consent value gets recorded in their EMR and is automatically transmitted to us.
Okay. So a couple more things. So first, do you have any, it must be written down somewhere what this new plan that's going to be implemented over the next year, is there something we can look at to understand that better without asking you to explain it in any detail?
I will have to see if the slide deck is disclosable.
Okay, that would be great. And otherwise, I may circle back to you because this is the prospective part, right? And we should reflect that the changes that are coming. And so I want you to finish whatever you think is essential for us to know. In the information you were just providing to us. But I also would love to focus, because we're going to run out of time, on a couple of these. I want to point out a couple of these questions, if you can fold them into your soliloquy here.
I mean, I think I'm kind of done with the soliloquy.
Well, no, I think we're going to okay, it's good. We can move on, but there is one other, the piece that I want to add to it, because again, you are farther ahead than I think probably most folks, is what we get to some of this. What a key lesson learned is lower. What obstacles have you encountered? That's important. But at a high level, you've had experience with this. What do people need to know who are working on consent that you feel like you have learned? I guess that's lesson learned. But what are the big takeaways here that if anybody's listening out there, they should hear the wisdom from somebody who's lived it?
I think the biggest one is that it's generally very easy to get a person to consent when you explain to them the value of sharing this information. When asked, and I use that qualifier because some of our sites aren't very good at asking, but when asked, more than 95% of patients say yes to consenting to having their data be accessed through the Rio.
You said 95?
More than 95, yeah, 95 to 98. And usually the places where they say no, it's at a substance use treatment facility.
Yeah.
And so, and it doesn't take long. I mean, a lot of times people, we have certain sites that have very low consent rates because they just say, oh, my registrars can't ask one more thing. We have other sites that have 100% consent rates that they get a yes or a no because they've built it into their workflow and they've trained their people how to do it. So that the implementation is not really that challenging, and the yes rates are generally quite high. So that being worried about that part of it, I think, is, a bit of a red herring.
Do you have any sense of if those consents, that 95% are actually informed consents? You know what I mean? Or is it like a paper under their nose, sign it?
It's really hard to tell, Chris. But I think that a lot of the experience, certainly that we've heard about, we don't have anyone We literally have not had a patient come to us and complain that somebody saw their data who shouldn't have seen their data, which I think is a pretty good indicator that they do understand. And we often hear anecdotally that, you know, when they're asked, there's like, you don't already have access to my data. And that's certainly come up in some of the focus groups that have been done. But I mean, I think there are definitely sites where it's just shoved under somebody's nose and they really don't know what they're signing. But
How about revocations? Any idea of what the rate of revocations are?
it's practically nothing.
That's good.
I mean, essentially, we say you can change your consent value at any time. It almost never happens.
You know, it occurs to me that this really is an answer, not the answer, to the perpetual complaint that all of us have. Why am I filling out the same form for the third frigging office or
Right.
the 20th time?
Why am I filling out all this medical history information over
Exactly.
and over and over?
Yeah, the issue has never been with the patient or consumer. It's always with the policy people and all that other stuff
Right.
that goes on, because even with HIPAA in the studies, people have no problem with HIPAA. It's like, why do we even need it? I want
Right,
to share my
exactly.
information.
Right. Yep. And so that's, you know, I think that, you know, where we don't find the issues are, you know, we find issues with the compliance people in some of the larger hospital systems don't want to share certain data because they don't believe that we can control it properly. So Montefiore doesn't send us their SUD data. It's ridiculous, but you know, they just are being incredibly conservative. Others do.
Can I follow up directly on that point?
Yeah.
Okay, because that is, that was actually one of my original questions. When you had said that, you know, once the organization joins the membership of the RIO and they sign the BAA, then they can send any data without written patient consent, additional patient consent.
Yep. But they get to choose, there's a certain minimum data set we require. That's demographics, MRN, all the identifying information. And then we want to get ADTs and diagnoses and procedures and medications and allergies and labs and radiology and all that. And we take the feeds by data type. And so as we go through those various data types, they may say when they're sending inpatient, well, I'm not going to send you my inpatient rehab unit. And we say, okay, because we have no leverage to tell them they must send everything.
So, but for the partners that are Part 2 programs, and the information that's coming to you comes with the Part 2 protection, since there's a requirement that for that data to be reshared, you have to get renewed patient consent to share it with the next body. So if someone were to download that information, right, yes, I mean,
so when you access, basically we tag all of our Part 2 data as it comes in so that we know every bit of data that came from a Part 2 location. And when someone is accessing that person's record, we have a disclaimer notification that goes up when a provider is accessing anybody's record that says this record may include data subject to 42 CFR Part 2 and is subject to consent requirements for redisclosure and other protections. You must be mindful of that as you handle this data, and you have to click I accept before you can go into the record. I mean, it doesn't have any teeth to it, and it doesn't, you know, and we don't have a follow-up. We don't audit what they did with it. We audit that they had a reason to access it that was appropriate, that they actually had a treatment relationship. But we don't audit their follow-up stuff. We're just not equipped or able to do that.
So I'm going to jump in again, see how far we get. So what you just gave was a terrific, I think, example of a lesson learned. There's a lesson everybody should get. Are any lessons learned relating to technology process that you think others should know about that they benefit from?
I think that, putting the ability to consent to access or sharing of one's data into the patient's hand on their phone will simplify all of this. Having a mobile consent app that can then pass that information on, that can say, yes, I'm consenting to such and such, or I'm consenting to ABC, and then route that where it needs to go, will just make a person's life that much simpler, and hopefully make the organization's lives, because you won't have to have the patient standing in front of you workflow have to be there to make it happen.
How about the technology for actually just being able to communicate with all of the different entities that you've put together?
I mean, that's basically our platform. It's native HIE in terms of our process for data ingestion and sharing of that. There aren't that many HIE vendors out there. There are a lot of data aggregators, but they don't do the same real-time kind of stuff that we do. I think there's one of our major lessons learned is in being very careful to validate our data as it comes in against the source data. We have a robust validation program in place where we check against their original EMR. We look at what has come into our system and is being displayed versus what's in their system before we ever bring them live. And they have to sign off on a package that says, yes, the Rio took my M for male and transformed it into male, or my number 1 for such and such and transformed it into this, and that's correct. Because that develops trust. When you actively go through data validation, when you're coming on board at the Rio, you recognize that we've got a robust process in place that makes sure that the data you're going to access is correct. So that if you've had to make sure that your data you're sending is shown correctly, then you've got trust that the fact that what you're seeing from somebody else's record is in fact right. And that, that was a huge barrier at the beginning, certainly.
And that's the big lesson learned for everybody from the get-go, is that it's about trust.
Mm-hmm.
I heard a great quote from one of my coworkers said, and I don't know if she got it from someone else, collaboration builds at the speed of trust.
Mm-hmm. Yeah.
That's good. We've got, I have more questions, but anybody else want to jump in with?
Do you have MOUs with each one of your members in the Rio?
We call it a participation agreement. It's basically a formal agreement that sets forth the terms. And if you go to our website, you can download a copy of it, see what's in it. And we have a set of policies and procedures that are attached to that participation agreement. That basically are things we are saying we will do and things we are requiring them to do. And we have pretty robust audit policies and procedures in place, and we have auditors on retainer and a very robust audit schedule to go in and do the audits that we say we're going to do. So it's all documented in writing, and the board of directors approves all of those policies and procedures.
So would that cover, though, the situation you mentioned with the one member who's decided that they're not going to share certain information?
Yeah, I mean, as I said, there's a basic set of data elements that we require for connection and setting up anybody to be live, to be able to look up their patients. We have to know who their patients are. But beyond that, it's their choice how much other data they send us.
Okay.
So the other primary question I want to hit you with is what are the challenges you've encountered? Technical or process or challenges that you've encountered, because those can obviously be as telling as the successes you've had.
I think certainly for us, the challenges have been primarily around I think the first thing is EMR vendor cooperation in terms of getting their attention to get the feeds set up to us. In some cases, there is still one EMR that refuses to put a Rio consent field into their registration screens because it's a modification and it's Practice Fusion. They were free and they basically didn't want to modify anything. But I think the biggest hurdle we have is getting through the ingestion process of getting the data feeds set up. Once those are done, mostly the data just flows. I think that the second side of it is in being able to integrate the workflow on the end user side. So that, for example, many of the EMRs cannot do a single sign-on kind of process. If you're in your ECW chart, you have to go to the Bronx Rio portal in a separate application and put in your credentials and log into a different system to look up the person's record. In Epic, however, or Allscripts, we've set up with the vendor to have single sign-on so that when you're in your chart in Epic, if there is consent there, you've got a tab for Bronx Rio and you hit that tab and you're right in the Rio record in patient context. So if they're looking at my record and I've signed the consent, they can click on that tab and see my Rio record right then and there. That's the gold standard for where we'd like to be because you don't want to make anybody leave their workflow.
Right. Right.
And so I think that's the biggest challenge on the getting usage side of this, of actually making the data get into people's hands, is making sure that we do that in a way that hits their workflow.
Any high-level takeaways relating to person ID or security or security?
I think less so on security, because I think, frankly, everybody is so hyped about it now that it is paid attention to, and it's generally in the hands of the geeks who care about it. Whereas patient identity, I'm just going to tear my hair out because it's at the core of all of this, and it's hard. We actually just initiated a new process with our Health Information Management Committee, which is composed of the HIM managers from our member sites and folks from registration and whatever that are collecting those demographics to try to get them to identify their best practices, promising practices around getting names spelled right and getting addresses correct. Because, we're the Bronx. I got 1,001 Diaz's with the same middle initial. If their address is wrong, I'm stuck about matching them. If their date of birth is wrong, I've got lots of other people with very complicated names to spell that get misspelled all the time. And so for us to match their records, it's a very manual process.
Yep.
And so we're working with them to see how they do it so that we can understand the beginning of it. Because it's a core of everything. One of our sites that's gold standard has literally put in retina cameras. And so they just, when they first enroll that person, they get all their demographic information and they actually make the patient hand them an ID. So they copy the stuff from a state or federal ID document. And then every time they come in, it's the retinal scan and they ask them to update their information, but they're sure that that person is that person. A lot of the others, folks are sharing IDs and we don't know who. We know they are because you see stuff that's inconsistent.
So this is
so this is the environment,
Okay. Again, I'm going to ask the group because we've only got a few minutes. and I can keep going on these questions and others that pop into the brain, but does anybody, Daniel or anyone, want to insert anything here before we get to the end of it?
I have two little questions, but Chris, I want to make sure that if you have stuff that is on top of your mind.
You go first, Daniel, because I can.
So question, Kathy, as we're talking about ink, and we've talked a lot about medical and SUD data here. I think I know the answer to this, but education data, justice data, juvenile data, court data, housing data, can that also technically be brought into, follow the same process? So you're the data trust, basically.
Yes.
Essentially you're a data trust. It doesn't matter what kind of data it is.
Correct. So I've essentially got two business lines going. One is my state certified HIE, and the other is my data aggregator work. And I apply, essentially we apply the consent rules to the data aggregator stuff for the most part. Some of it's covered with QSOAs and BAAs between the different partners. But as we look to bring in housing data or education data or child welfare data or juvenile justice, those are going to get governed by DUAs with those organizations. And we've all agreed internally within INC. The partners are going to have to get consent to access the INC aggregated database.
Partners are going to have to get, who the partners?
All the organizations that are part of B Inc. New York.
Okay, great. Right. So they're going to have to get consent from the individuals or the guardians
or the family.
But they're just going to the data trust. That's
right.
You're the bank basically.
Yeah.
For that, and you can apply all those same sort of security identification, all those kind of things are still managed within that. Are not still, but are managed in the same way.
Yes.
And so INC is the data trust.
No,
INC is one client of
it's one. Oh yeah, I'm sorry, I was mixing. Yeah, I got it.
So if you're a data aggregator, well, I think of that as you're aggregating. Okay, so are you processing the data so that each organization can look at their processed information, or is there individual? You can look at individual data, or is the data aggregator just serving the purpose of aggregating it for population health studies?
No, so for INC, what I'm doing is bringing in the data from multiple sources, claims, healthcare providers, health plans, community-based organizations, linking the data of those patients across all those different organizations, and then making it available either through a patient portal lookup or through aggregated reporting or through aggregate reports that have identifiable line item backup to them, depending on what the use case says is the need for those end users to have that data. I'm being a data warehouse for them.
Plus more than just a data warehouse.
Yeah. I'm also doing analytics on it and, giving them summary data as well as giving them access to, individual data. So for example, a case manager supervisor could get a list of all of the people on that case manager's roster and what had been done with them recently, if they needed it for supervision purposes, for example.
If I were you, I would be tired. Okay.
I have another question.
Go.
All right, so my other question is, how have you dealt with when consent expires? Because at least I know under part 2, I think you have to have an expiration date written on your consent, I think, unless that's changed.
Our consent basically has a date of expiring 50 years after your death.
Oh, no problem.
We often don't know when you die.
For 50 years.
So that's the New York State standard that keeps us in compliance with part 2. This consent is good until you change it or until 50 years after your death.
you know, you may be setting yourself up for some false advertising claims with 86-year-olds.
Yeah.
So I'm not sure that would comply with part 2. That just, it's a question for me.
Again, we're not. It's been judged by all the lawyers that have looked at it to be part 2 compliant.
Mhm.
Because we're basically essentially just disclosing it on the basis of the patient saying, yes, this organization can look at my data.
Yeah, I'm not challenging you. I'm just kind of like flagging it as a, you know, good for you if you got the lawyers to agree to it.
They did. We wouldn't be doing it if they didn't. It's a statewide
Yeah, no.
standard.
All right, I'm going to wrap it.
I need to ask 2 more little
Yeah,
questions. I'm sorry.
of course you do. Please.
That was me too well.
We just met.
So based on what this last conversation, one of the things that would want to be very careful around doing is saying they're doing it here, it's acceptable, it's been deemed kosher by New York State attorneys for that within this context. Because oftentimes what we hear is, show me who's doing it, right? Show me who's doing it. So not that we're going to necessarily wave that flag, but that's a really important thing, is if, to your point, because part of the challenge is to, I'm sure, continue to manage those consent starts and finishes and that kind of thing. So we'll want to just highlight that in a way to make sure that we're comfortable sharing that in a way, because and one other quick question, or I think 1.5 other quick questions. One, so anybody who's got an HIE theoretically could adopt or adapt or configure them into sort of a data trust, a data aggregation, similar to what you're doing and you're pursuing, right? Because my understanding is much HIEs are just really health related. They're not thinking about the other kinds of services or supports or programs.
That is correct. There are probably a handful of us who are doing what we're doing.
Right.
And a whole bunch of others that are not that mature yet.
Right. So, but that could be the engine that gets replicated for the data.
Yeah, conceivably. Yeah.
So that's one good thing, sort of the meta takeaway is that, you know, is there a model that can be replicated with maturity that will really handle the flow of all sorts of different kinds of data? The last question I had though is, what about states that are opt-out? So Christine talks a lot about opt-out states. How does that change the process at all, or does it?
It would absolutely change it, because what you need, but it changes it in some ways. So, for example, California is opt-out, and what we understood, and this goes back a long time, so it may not still be accurate, but when I first started learning about a lot of this, what I learned from the California folks was that it was just as onerous to document that you've done the education to gain the opt-out than it was to have gotten an opt-in consent, because they had consumer groups that made them, you know, go through a whole process. I don't think that's true in a lot of other opt-out states, but I think the fundamental issue with the opt-out, you know, the technology is very similar, because you still have to have a mechanism for sending a message that says no rather than yes, or rather than our yes, no. But the bottom line is, when you're opt-out, you're totally locked out of the Part 2 data without implementing a second whole workflow process to collect that.
So so Part 2 requires an opt-in?
Yes. There has to be an affirmative consent on record for Part 2 access.
Didn't Ken say that that's changing with the new regulations? So it could be either?
That's not changing. They're changing in other ways.
Okay, that's a different conversation.
Yeah. They're not eliminating the affirmative consent requirement.
Yeah, when he's talked a lot about opt-in, opt-out, I haven't been really clear on what he means by that, because that's not the stuff that I've seen has changed with the new
Right.
rules. And you do have to give affirmative consent.
Yeah,
But he
what,
knows his stuff, so that's why I figure I haven't just seen the right stuff yet to read.
yeah, I mean, I have not seen anything coming out of SAMHSA that says they're eliminating the opt-in requirement. They've changed certain things to make it easier, to give you the ability to use language that allows a broader group of providers to access the data with your consent. It used to be every single organization had to be named.
And the individual you're going to give it to in the organization. So they've
And the
like
language has loosened up around that very substantially.
Okay.
Um,
But we'll hear more about that when we talk to both Ken and Michelle, who's sort of doing the consent to share. So literally the final question. So the value add here is putting the consent process into the person's hands, the consumer, patient, client's hands, to say, I'm giving my consent for whether it's HIPAA, FERPA, 42 CFR. That facilitates the process on everything else that downstream from that for the Brown Trio, right? So just confirming that that's the value proposition, that there's a common way of doing that, that it's simple,
Right.
it's understandable, it complies.
because as I'm, our technology historically has been based on, HL7V2 and CCD data moving back and forth and providing people access to our data through either sending a CCD upon request or giving them portal access. And if they want to keep it, they take a screenshot of whatever they're looking for, or in a report that they access or we download to them. With the FHIR API methodology coming into play going forward, where I now have the ability to respond to a query that asks me to provide this nugget of information about this person and to send it to so-and-so. I have to know that the recipient of that has the patient's consent as part of that whole query response process, because it's going someplace outside of my own network, essentially.
Mm-hmm.
And so as I look at evaluating requests from API developers, part of our process with them is, how are you going to document that you've got the patient's consent for me to give you this data?
Mm-hmm.
And how are you going to tell me that?
Okay.
Okay. Because it's a completely different set of transactions than I'm used to doing historically.
So that's going to really be a requirement for actually enabling FHIR APIs, is to be able to have that granular consent from the consumer. Otherwise, it's not going to be possible.
For us in New York, yes.
Yeah. Okay. Great.
Kathy, it would be great if you could, I don't know if you had seen in the chat, but not just your consent, but the consent you referred to from the upstate Rio. That would be great if we could see that. And there was one other document that you mentioned. If you're okay with just, releasing it just for the exclusive purpose of Jennifer Bernstein and I to look at it.
So there were two other things on my list. One is the participation agreement, which lays out all the terms of our relationships with our members. And the other was if I can get the permission to share with you the slides about the new all-in consent model.
Yeah.
Because right now that's just in a slide deck. It hasn't gone any farther than that. There are no specifications. There's nothing else. So.
Okay.
And your participating agreement, sorry, with the CBOs is the same as the participating agreement.
Yeah, we have one agreement. We don't change it for anybody. We have 2 side letters out of our hundreds of participants that specify a different term for something. So for example, one is around research, where we have a side letter with our major academic medical center that says they reserve the right to review and approve every research request that we get for their identified data. And then we have another side letter from the State Department of Health. But everybody else has just signed the regular agreement without any
Great.
other side letter stuff.
Kathy, that's great. I'm glad you were first.
Glad it's over with.
No, so the only, just so you don't get delusional here. If you don't mind, we'll send you the set of questions, and if you don't add anything, it's fine.
Okay,
But if you see something, if you think of something you should have added or want to add,
Okay.
please do. Okay.
sounds good.
All right.
All right.
Great.
Nice
Yeah,
to see
Anybody
everybody.
else?
We have
Anybody else
definitely used
before
up
we
our-
say
our-
arrivederci?
we've definitely used up our chits for this week. Thank you, Kathy.
Thank you.
No problem. I'll see you guys soon.
Yeah,
Bye.
terrific. Yeah, thanks so
Thanks, Bill.
much.
Thank you.
Sure.
Take care, everybody.